Hello, welcome everyone. My name is Susheel Kodali from Columbia University in New York. It's great to be back in Paris and EuroPCR, and we have an exciting discussion today talking about the early safety and feasibility of a first-in-class biomimetic transcatheter aortic valve called DurAVR. I'm joined by my friends and colleagues, Chris Meduri from Karolinska University in Stockholm, and João Cavalcante from Minneapolis Heart Institute. So welcome, Chris. João, welcome.
Thank you, Susheel.
So we want to start a little bit. I mean, TAVR over the last 15 years has really evolved from a niche procedure in high-risk patients to really being done in low-risk patients. And as such, a lot of the conversations have changed. It's not just about, can we get the valve in? Can we treat the patient? Are they going home? It's really about, what is the result of the TAVR? What kind of gradients are we getting? What kind of valve areas are we getting? What is the durability and sort of the lifetime management of a patient with aortic stenosis? So, João, you want to comment a little bit about this shifting conversation? You know, why do hemodynamics matter?
Yeah, no, thank you again. And I think that we have learned through the years that now we can do this procedure safely, and it's becoming much more predictable. And that was quite a long learning that you and Chris and many others have contributed to that field. When it comes down to understand that once we place that valve, we are trading one problem for another. And we wanted that second problem to not be a bigger than what it was. And we wanted this problem to obviously not become an issue from the beginning. And so along over time, this unloading of the ventricle by fixing the valve with TAVR has really helped us out to understand that the ventricle over time with the pressure overload becomes muscular, becomes thickened, becomes fibrotic. And trying to reduce that with the TAVR, with the lower gradients and avoiding prosthesis patient mismatch has been a great way to improve not only their symptoms, the remodeling, but obviously the outcomes of these patients. And so I think when we now have been doing this safely and predictably, it becomes now the scrutiny of what provides the best unloading of that ventricle, what can be done so that we can retrieve and recover as much as possible this ventricle that has been suffering for quite some time. And as we will hear as well, the ventricular disease, the aortic stenosis is not just the valve, but the ventricles and the arteries. And I think all that continuum is something that we have been very fortunate to start the exploration, as we will talk about.
No, it's a great point. And one thing that always comes up is, you know, we get a certain valve area, and a lot of the patients we're treating are older. They're in their 80s and 90s, and their activity level is different. Now, as you get to younger patients and they're more active, you know, what is the impact of patient prosthesis mismatch for, you know, in a younger patient who's maybe, you know, biking 10 miles or 15 miles, and, you know, obviously larger is better in these patients. And in addition to a larger valve, which I think will be more important in younger patients, you know, when we put a valve in, you know, surgeons take the diseased valve out, they put a surgical valve. Yeah. You know, the goal for all of these, we're never going to restore native valve flow, or perhaps we can. I think that's one of the questions, because flow is so important. And you've done a lot. We're looking at halt leaflet thrombosis, other factors. What is the implication of abnormal flow post-TAVR? I mean, do we know yet? I mean, does this matter? Do the flow dynamics matter?
That's a great question. And we were mounting the data. I mean, there's some suggestion that, you know, flow definitely matters for the arteries particularly, and for the ventricular unloading. When we talk, for example, bicuspid patients, we know that abnormal opening is going to create a greater wall shear stress, a greater eccentricity. A normal flow, a laminar flow, should be that in which the Vmax, the center of the velocity, should be at the centroid of that vessel. The more eccentric, the more displaced that flow it is, the more will be the repercussion of that flow into the crosstalks between the ventricle and the arteries. So yes, definitely, if we could restore the pre-disease state, and particularly using the biomimetic design, which Chris is going to touch upon, if we could replicate how that valve was once upon a time, once replacing that would be ideal. There is some suggestion that whether we use balloon expandable current platforms as well as self-expanding, there does not seem to be restoration. And even surgical valves, that there seems to be some flow eccentricity, that we never are able to restore the truly laminar flow that was once how these patients were born with. So that might have implications. We are looking at obviously the long-term implications of that, but at least some preliminary data seems to show that yes, we are able to restore that, and we will talk more about that later.
So what you're saying is if we're storing sort of normal flow, we'll probably unload the ventricle better and reduce the stress on the aorta. Is that sort of
exactly? Yeah, because
it?
as the ventricle tries to unload, it has to pass through that now new valve. But if it hits the aorta, there's going to be a pushback. There's going to be what we call a reversal of flow, even in systole. Right, so you're pushing against the resistance, as opposed to trying to push that into the center of the vessel. There will be completely unparalleled resistance. So, I think that it's something that is intriguing, that we are starting to understand. But some preliminary studies have shown that both in self-expanding, balloon expanding, and surgical valves, that restoration of laminar flow does not seem to occur in all patients.
That's fascinating. That's great. Now, Chris, you've been working on DurAVR for several years now. Part of the premise here, as you sort of explained to me earlier, is we want to start from sort of ground zero and try and mimic a native valve and try and develop a transcatheter valve that sort of improves these dynamics that João has been talking about and potentially has increased durability. Do you want to talk a little bit about the DurAVR design and the theoretical sort of benefits of it?
No, absolutely. Thank you, Susheel. No, I think you're exactly right. Listen, if we look throughout, various things in our lives, things that are more like nature tend to effectively work better. And when we look at heart valves, yes, they're now bioprosthetic valves tend to open and close like a native valve does. But if you look at the actual physical structure design, they're actually quite different. And what we tried to do with DurAVR, which yourself and quite a few others were involved at the early days of this, was take a bovine pericardial tissue that's flat, and instead of just taking 3 pieces of it and cutting into pieces and suturing it into a valve, we wanted to be able to mold it into the shape of the native aortic valve by molding, not by taking 3 flat pieces and suturing it. And the goal has been, by molding this tissue process, we would hope that we could actually restore both hemodynamic performance and, as João was just talking about, this flow, laminar flow performance to a native or pre-disease state, which we know, as we're alluding to, doesn't really happen with current valve designs. And so that really has been the goal of the design of this, and the target, I think we'll see now with our therapies, with our results clinically, the performance we're seeing with the valve. And so the idea here is this is now not just a bioprosthetic valve, but a biomimetic valve. Bio and mimetic mimicking the native aortic valve. So a first-in-class biomimetic valve.
That's great. So why don't we talk a little bit about what we have thus far from it, right? I mean, this is now done human cases. All of these theoretical concepts are great, but if you can't get the valve in simply and safely, they don't matter. So in the end, we have to sort of make sure that this device can be implanted safely and effectively. So the data here that's shown is the initial 13 patients that were done. The valve is a balloon expandable valve on a balloon expandable frame with the valve design as you sort of described. All 13 cases were done successfully. And what you see here are the sort of the hemodynamic results. So, these were patients with an annular diameter mean annular diameter just under 23 millimeters. So on the small side. And initially we got effective orifice areas of about 2 centimeters, and index valve areas of over 1.1. And one of the things that we often don't look at, and I think it's probably more important and we often underappreciate, is the DVI, because that's really showing the effective unloading and the gradients relative. And the DVIs that we got in the initial 13 were quite remarkable, of 0.53. And the patients had single-digit gradients of 9. And so these results are outstanding at 30 days. And, we have a limited cohort out to 1 year. Obviously, this is early cases. So 5 patients thus far have reached the 1-year endpoint. There were no 30-day mortalities. All patients did well, recovered, went home. And 5 patients thus far have reached the 1-year endpoint. And you see that the hemodynamics are maintained. The valve errors are just around 2. The indexed errors are still above 1.1. The DVIs are 0.4, and the mean gradients are still low single digits at 1 year, which is remarkable. And I think that if these results can be maintained, especially for patients with an annular size less than 23, this is quite a bit different than what we see with currently available balloon expandable devices. So I think it's encouraging. This is 13 patients. There are an additional 8 that were done recently. Maybe you want to speak to them?
Yeah, no, thanks, Susheel. I mean, I think you said it right. I mean, again, this is our first human experience. We had out to 21 patients. No real significant procedural complications, which in and of itself, I think, is a big deal. And already 21, first 21 patients.
Any pacemakers? I forgot
No pacemakers implanted in the first 30 days across all these patients. With, of course, the last date or discharge without pacemakers. Still, we're waiting for the final results of that as well. We've even seen even further improvements. I think in the newer cohort, a DVI is 0.59 now in the last 8 patients. Really no PVL, no central leak, really issues whatsoever. As mean you were there in the last 8 patients as well. So really encouraging results. And I think we continue to see, that this is a durable product. And it's, we've both done these cases. It's pretty easy to implant the technology. It's balloon expandable. We know we're familiar with those type of therapies. And so, I think this is, when you get out to 21 patients, I think it's not just 4 or 5, but like you said, this now goes back to, all right, well, there is a unique design here. It's biomimetic, not bioprosthetic. And that unique design is now translating to the unique clinical results, right? Nothing, you don't even see EOAs this big with the 29 Sapien or maybe with the 34 Evolute, do you really get consistently this type of hemodynamic performance. So to see this in such small anuses, I think is really unique. And again, goes back to the unique design. It's not chance, it's because it's been designed differently.
And then perhaps, one of the advantages of doing these sort of smaller studies is you can look at other characteristics. I mean, João, you talked a lot about flow and how we can normalize flow. So MRI is a great tool to look at flow. Perhaps you want to talk a little bit about, there was MRIs obtained in these patients, and all this stuff is confusing to me. Perhaps you can simplify it a little bit and sort of explain what we're looking at and what you're trying to understand here with these MRIs, both pre and post TAVR.
For sure. No, I'll make it simple for you, Susheel, and for all the other viewers here. What we're trying to show with the MRI is really what I had described before. A normal opening valve should try to open as much as possible so that that flow, the column of blood, can come uniformly through the ascending aorta without hitting the walls and without losing its kinetic energy or dissipating or creating wall shear stress. So on the top left, what you see is a patient without the aortic stenosis, healthy aortic valve. As the valve is opening, you cross-sectioning the aorta, and you can see that column of red blood coming as a uniform. It fills it out the entire blood vessel. What you see on the right side is after a TAVR with the DurAVR system, and you can see in systole as well, that same full column of blood. And now it's not only just looking at the pictures, but also trying to measure and quantifying, which is MRI is quite good. So a normal vessel, a normal prosthesis, and a biomimetic prosthesis that mimics the original valve should try to not have a lot of displacement of flow. Contrast what you see there with DurAVR on the top right with the other 3 disease states. You have severe AS on the bottom left. You can see that flow is quite eccentric. You can see that on the coronal view. You can see that in a through plane. You can see that jet hitting anteriorly and creating obviously increased wall shear stress. You see 2 other valves as well. 3 other valves. You see a balloon expandable, you see a self-expanding, and you see a surgical valve. All of them not being able to restore, creating a greater flow displacement. So it's displacing the flow from its center. And by doing that, you increase also what we call this reversal ratio. So even in systole, the flow is not being able to transverse and go completely full speed ahead, it's hitting the wall and it's turning its way down, which is losing of the kinetic and the momentum energy. So this is in big, have to acknowledge here our great friend and colleague Pankaj Garg, who has worked tirelessly to being able to provide these different insights. When we're thinking about that aortic stenosis, again, is not just a disease of the valve, the ventricle, but the arteries. Could that have implications into how this ventricle is going to be unloaded? Could this be much more favorable to these arteries? Could this be much more favorable to the durability of that prosthesis as well, because of this less opportunity to lose kinetic energy and being open the leaflets with much less force? So all of that is something that we're going to be tracking along, and really exciting to see these preliminary results.
That's fascinating. I mean, it's great preliminary data. Obviously, we need a lot more. This is early, and we need to look at all the other factors that impact flow, both with DurAVR, but also the other devices, as you've shown here. And whether it's aortic angles, it's bicuspid valves, it's other things that are going to impact as well. And I think this is great, exciting data. It's starting the conversation about what we have to start talking about, not just about relieving the AS, but normalizing flow, unloading the ventricle, reducing stress on the aorta. And over time, I think we're going to have to collect more and more data, and these are going to be critical factors to look at. I really want to thank both of you for sort of helping to sort of navigate this conversation, really highlighted important points. And I want to thank all of our viewers for joining us. And again, excited to be back here at EuroPCR with everyone in Paris. Thank you again.